So good evening once more. Hello, you can get me?
Loud and clear, Mr. Mulenga.
Okay,
Loud and clear, sir.
Okay, so
loud and clear.
Thank you so much. But I can't. Okay, I can now see my slides now. So the topic for today is the role of transvaginal ultrasound in diagnosis of FGTB, which is female genital tuberculosis. I decided to present this case simply because we are also affected being a developing country. And not only that, you all agree with me that tuberculosis, it's one of the leading causes of death in developing countries. And it must be mentioned here that this disease, it's not new to most of us Africans because of its burden in most of the countries. Other countries have managed to control it and it has minimized. However, it must be understood that we know tuberculosis by its effect on the lungs and the respiratory system. And half the time, whenever we are treating this, we concentrate so much on the TB of the abdomen, TB of the lungs. Yes, the primary infection is from the lungs, but we must be aware that this TB may also affect the reproductive system, both in males and in females. However, research has continued to show that the TB dissemination is more pronounced in female, and because of the bacteria itself that may affect or descend into the reproductive system. This may be due to hematogenous or through the lymphatic system, and it may find itself down into the reproductive system. And the disease burden among women also leads to infertility. I think this is very key, that must be understood. The major burden among women with the tuberculosis, it leads to infertility, and it tends to distract the fallopian tubes and just damage them. Sometimes when it's there, you may not actually see it because this may be due to other superimposing, or it may actually mimic other conditions that may come. So the spread has to be understood from one context that may come. So my presentation is very short because there's nothing new that I'm going to present. I just want to highlight so that people can be aware. I've seen, I think, 2 cases during my practice, 2 or 3 cases. It was confirmed to be FGTP, female genital tuberculosis. You may have also come across these sonographic presentation that I'm going to present, but because you were biased to think of other things, maybe it didn't click. No wonder we always emphasize whenever we are doing these cases to further correlate clinical findings with sonographic findings, even do your lab findings so that you come up with a conclusive report that may help. So I'll define what FGTP is, the prevalence, the pathophysiology, the common sonographic features, and some of the complications that it may lead. I've already alluded to some of the complications, being infertility and tubal damage that may come. So what exactly is this FGTP? So it's a chronic condition which is caused by mycobacteria, same bacteria that we know. Mycobacteria tuberculosis bacilli that commonly affects the fallopian tubes and endometrial involvement. This bacteria, as we may know, it can be very stubborn, and the disease may present to be chronic in some cases. Just like the way it may cause some fibrotic changes, and it may also be latent, it may also almost present the same in this reproductive system. So this mycobacterial bacilli may reach the genital tract primarily through the hematogenous spread. Like I mentioned, this may be due may be due to hematogenous or through the lymphatic system. So as long as we are having this bacteria with us, it may find its way in certain reproductive systems and it may affect them. And almost about 98% of female genital tuberculosis affects the fallopian tubes and the endometrial involvement. And each chronic disease with low-grade symptoms may actually mimic other gynecological conditions, which may be very difficult to pick once you just go through it. Again, I should also mention that many patients who present with, they actually present with atypical symptoms, which again may mimic gynecological conditions. And several investigations, again, I emphasize, they are needed to establish the diagnosis. As you may be aware, the practice of medicine now, it's evidence-based. So whatever we are doing, be it under sonography, be it under the actual diagnosis, even in the labs, people want to know exactly what are we dealing with? What other supporting clinical findings are there? What other lab findings are there? How is the patient presenting? It's also very important to learn that almost all cases of genital TB affect the fallopian tubes and they cause infertility in patients together with endometrial involvements. It goes further to say that the current treatment for these cases, again, it's simple, the antibiotics that has been used in most of these treatments. It's the same TB that we are dealing with, except sometimes we don't know how much it can disseminate. And again, I should also mention that the combination of, depending on the damage that has been caused, this may also lead to surgery where the tubes may be removed. And then the patient may also go further to present with other complications that may come. Epidemiological changes also becomes also very important to note. So some of the things that we have to consider is how is the morbidity and mortality of this. The mortality and morbidity of this disease is quite high worldwide, especially in developing countries. I don't know why developing countries are always the factor of this, but it's unfortunate that we are having this disease in developing countries, but which doesn't mean this cannot be eradicated. The bacteria can spread, like I mentioned, through the lungs into the reproductive system, and many patients present with atypical symptoms, which mimicking those gynecological conditions. And I've already mentioned that this condition affects the fallopian tubes and ends up with infertility that may come. How is the prevalence or the epidemiological data? You find that TB being one of the major health problems affecting about 10 million worldwide in 2017. This is by research which has been done previously. I think about 10 million people were affected in 2017, and approximately about 1.5 million deaths were recorded due to this tuberculosis. So we can see the burden is quite huge and we should not take this for granted. 2017 is not far from now. We are talking about some few years that has elapsed. India being one of the leading countries with high prevalence of TB, followed by Indonesia, followed by China, followed by Philippines, Pakistan, Nigeria, South Africa, and the list goes on. So you find that we've not been spared as Africa, and you can see South Africa is also on the list, and there are many other countries that we may list. But according to that research that was done, the prevalence showed that we had so much TB during that period of that. And it's also very important to note that actually Bangladesh also was one of the countries that were also involved with this. And you may also realize that these days they actually occur more into males than females. However, we should also know that amongst the females, this female genital tuberculosis, one of the essential factors is infertility. So once it attacks the females, it tends to mess up with the fallopian tubes, and also it may actually also occur secondary to pulmonary tuberculosis, which may disseminate through that. The site of infection also is very important. I've already mentioned that it may affect the 98%, it may affect the tubes, and almost 100%, it may involve both fallopian tubes bilaterally. So patients may present with tuberculosis, which we may see on ultrasound, and patient may also have infection of the uterus, about 50 to 60%, often secondary to the adjacent structures again. Then you've got about 4 to 6% again, that may involve the cervix, and then this may also involve the ovaries. You also find that these cases may also present like pelvic inflammatory disease. No wonder sometimes it's very, very difficult to pick exactly what is happening within the pelvic cavity, not until you do further investigations and then you do the culture and sensitivity to isolate the bacterium. At least it may give you differentials to note that you're dealing with a possible bacilli. Like I mentioned, the spread being hematogenous or lymphatics, it tends to be more direct spread, and the tuberculosis itself in female can result in serious damage to the reproductive system. And a therapy of this, like I mentioned, it's a standard treatment for bacteria that may come. So what is the role of ultrasound? The role of ultrasound becomes very important because certain features that you may present may also be very important to note. So I'm just trying to illustrate what we already know. So you may have the fallopian tubes being affected. We've got about 90 to 100% affecting the fallopian tubes bilaterally. It may affect the endometrial involvement. Then we have 5 to 35% of the cervical portion. So you may see that the patients may have different parts that may be affected by this. But what is key is that this tuberculosis may affect the whole reproductive system that may present. And this may involve the myometrium, may involve the vagina, involve the vulva. It may also go further and affect most of the reproductive system that may be there. And both fallopian tubes, if you're affected, they may involve almost 90%. But more importantly, you also find that salpingitis is one of the major presentations that the patient may have. So how do these patients present? This is just the pathogenesis, the genital TB. It comes through always secondary from the primary usually from the pulmonary infection. Sometimes it may also be affecting the renal, the GIT tract, and then the bone, and generalize the media representation. And the mode of spread, like I've mentioned, it's maybe hematogenous or lymphatics, and sometimes direct by intra-abdominal or peritoneal focus. So you may realize that sometimes the TB may disseminate to the abdomen, resulting into extrapulmonary tuberculosis. And we know that the presentation of TB affecting TB of the abdomen may have a typical presentation of echogenic strands of ascites that may present, quite thick echogenic strands that may present. Even then, you cannot conclude just by looking at it because it may mimic a lot of things, but it's very important to aspirate, and then you do culture and sensitivity. So having TB of the abdomen and considering that the reproductive system of the female, you find that there is that communication anatomically that is there. So that must also give you a hint that this patient may be predisposed to have female genital tuberculosis that may present. And then what is the typical presentation of a patient with female genital tuberculosis? So the presentation depends on the site of infection. And by site of infection, I'm trying to explain it may be due to affecting the fallopian tubes, which may account to 90 to 100%. And then 40% of the patients, they present with infertility. It may be secondary or primary infertility, depending on the age and depending on the clinical history. But the key major things are that these patients, they tend to be asymptomatic. You can't even know that these patients are presenting with this, or this may be due to tuberculosis. And I've also noticed as sonographers, radiographers, and all of us who are doing ultrasound, sometimes we don't even bother to check through the clinical notes if the patient had previous investigations or previous infection on tuberculosis. Sometimes they also hide. I don't know in other countries, but I think in the past people used to relate tuberculosis with HIV and all those things. So people will tell you, no, I've never had TB, and they simply take you off the ladder on one of the diagnoses that you may have. But the key message is that we need to be thorough when it comes to clinical assessment, gathering the information so that we have this hypothesis before we even conclude. You may realize that most of the sonographic presentation that a patient may come, it links so well with the history that you are picking from the patient. And most common presentation is infertility. And we know the WHO definition of infertility being that infertility is failure of a woman or a man to conceive or to pregnant after having consistent unprotected coitus for 1 year. I don't know whether the definition has changed, but the definition still stands that infertility has to elapse consistent unprotected coitus for 1 year. That's when you can say somebody can be declared this is infertility. And then the other presentation is that patients may also have these blocked damaged tubes, which you can see in other imaging modalities like plain X-ray, HSG, and all those. You may also find that depending on the extent of damage and the involvement, either the endometrium is involved and the fallopian tubes, patients, when you do an HSG, they may also have this Asherman syndrome kind of appearance on HSG. So that Asherman syndrome, of course, it has got its own typical cause, but patients may also present with such kind of HSG image presentation. That may give you a clue to say, I may be dealing with the patients who may be having female genital tuberculosis. So typically, sonographic findings may show you things like that. I think you can see this is our uterus in sagittal. There is our endometrial portion there, the perimetrium. But immediately when you look at it, you find that there is this fluid around with the echogenic strands. This is also typical that we see in TB of the abdomen. But this presentation typically may give you a clue to know I may be dealing with the female genital tuberculosis. You can see both in sagittal and in transverse. And I should also mention, I know we are doing it, but always do your scan at 2 orthogonal planes. You pick your sagittal and you pick your transverse. The reason is very simple. You need to appreciate the image from different views so that you can also conclude on what may be happening there. You can also see that you can't even appreciate really the adnexia and the ovaries, but what is so clear is that the uterus is just swimming in this fluid that is there. So this is one classical presentation of female genital tuberculosis. I should also mention that this presentation may also mimic other gynecological things that you may have. And most patients may also experience chronic lower abdominal and pelvic pain, which is also classical in the PID, pelvic inflammatory disease. And this, again, may be accompanied by other several characteristics of pelvic masses. You can also have pelvic mass, pelvic cysts. You can also have pelvic abscesses. You can also have things like menstrual dysfunction. Remember, this is a bacteria that can also affect the ovaries, and we know the role of the ovaries in the regulation of female hormonal secretion. So all those presentations may be affected due to the effect of the bacteria on the reproductive system. So all these things becomes very key. The menstrual dysfunction, patients may also present with dysmenorrhea. Patient may also be having this postmenopausal bleeding. But again, you also have to be very careful so that you isolate what are you dealing with. Because when you ask me things like postmenopausal bleeding, there are quite a number of conditions that a patient may present with postmenopausal bleeding. There are quite a number of conditions that a patient may present with lower abdominal pain. There are quite a number of cases where a patient may present with the pelvic abscess. Quite a number of things where you can just see there is a mass, there is a cyst, and including this menstrual dysfunction that I'm emphasizing on. So rule out things like, how is the hormonal status of this patient? Have they done any hormonal profile? How is the condition of the uterus? How is the condition of other predisposing factor? Are these patients maybe seroreactive? Are these patients any history of TB? So the tendency of wanting to do all these investigations becomes very key. If you see fluid like this, I think there is no harm to also do caudecentosis so that you check what kind of fluid are you doing, and then you take it for culture and sensitivity so that they isolate this bacteria. And on top of that, findings of these symptoms in female patients with infertility may lead to a diagnosis of female genital tuberculosis. And it's very, very important, even as we stand, to consider those investigations that we have mentioned. I know one time we agreed on this fora that the best way to appreciate the uterus in patients with the pelvic ultrasound, typically we use a TVS. I know we are not doing much of this because of reasons, protocols, and basically failing to convince a patient and all those things. But certain lesions or abnormalities may be well appreciated very, very well when you do a TVS, so that you have a clear outline of what may be happening there. So when you look at this, we have the perimetrium here with the bowels just adjacent. This is our perimetrium all the way up to there. We've got our urinary bladder, which is just here. And then when you look at the endometrial, the upper portion of the uterine segment, and there is that echogenic foci, calcified foci lesion that we are seeing. And then you come down here, the cervical portion, there is that. So when you look at this, it can mean anything. It can mean anything. And if you show somebody to say, what is this? They'll tell you what they think. But again, I will emphasize to say, once you have the clinical picture, once you have the clinical history, and once you have also certain parameters that may guide you to look at this, you are likely to give at least a differential. So one of the things that you may find that this is a calcification that may have appeared there. Remember, tuberculosis, it's a chronic disease. So it may present with the fibrotic changes, the gun focus, and all those things that we see. We may also see it in there, and it may present like that. So this was a typical presentation of a case of chronic tuberculosis endometritis. It had affected also the endometrium, and it also affected the line. But you can see that it's very difficult to just pick it. But you agree with me, for those of us who have been scanning, that this doesn't look a normal endometrial cavity because of those hypoechoic areas around here. One may be tempted to think we may be dealing with possible edema that may be there, subacute or chronic, but you can tell that this is not a proper outline. But again, you also have to be very careful. One of the protocols that we emphasize when doing this, always measure the endometrial thickness. With experience, again, it's very easy to say, oh, there's something wrong that is happening there. As we may know that the cyclic changes in the endometrium also plays an important role. So whenever you are doing a pelvic scan, emphasize on the endometrial thickness. Is it in the menstrual phase? Is it proliferative phase? Is it also in the secretory phase? More importantly, you have to be aware and know the age. Are you dealing with a reproductive age, or are you dealing with a post-menopause age? This time around, Africans, we are also now indulging into hormonal therapy. So don't underrate an endometrial thickness of maybe for argument's sake, somebody who is around 56, 57 years, and then you find the endometrial thickness, maybe it's around 12 millimeters. Okay, ideally, it shouldn't be around that much when you are around that age. But patients, some of the patients, they tend to be on hormonal therapy. If they're not on hormonal therapy, again, you have to start thinking of things like endometrial hyperplasia. Are we dealing with a possible abnormality of the endometrium? So the point is, you really have to integrate things and come up with something. There is also another tendency where we are also underrating this endometriosis. Endometriosis can also be a very, very serious, it can be subtle depending on how it's presenting. But we all know that endometriosis affects most of the adnexia, the ovaries, but you may also find that it may affect the cervical portion, the myometrium, even as far as the lungs, it may also present like that. So the holistic approach to these investigations becomes very key. So this type of lesion that you have here, it's not a simple lesion where you can just say this is that, but it can mean chronic infection, chronic inflammation that had occurred after some time. This was a case of hydrosalpinx of a 27-year-old woman with failure to conceive. And then ultrasound image was done. Again, this was a TVS. You can see the walls of this were quite thickened. So this was a tube that was dilated with multiple incomplete septations that was there. So hydrosalpinx, again, you also have to be very careful. Sometimes with a transabdominal approach, you may not see everything, but a patient may present with such findings which may lead you to know you may be dealing with this. Again, when we talk about hydrosalpinx, are we dealing with pyosalpinx? Are we dealing with just a fluid within there? Are we dealing with, so all those findings on ultrasound becomes very key to consider. And once we conclude and correlate things in relation to what we are finding, it becomes very easy to give differential diagnosis. And we all know that if you are having things like pyosalpinx, hydrosalpinx, definitely a patient may not have those things that you may be thinking they are affected. You can also have things like tuberculosis peritonitis. We know that peritonitis is nothing but inflammation of the peritoneum. And when you look at this again, the presentation tends to be consistent. So you may have this chronic on acute presentation of female genital tuberculosis that may also present with the peritonitis. It becomes very key again as a person who's doing an ultrasound, analyze exactly what am I be dealing with? Am I dealing with just typical a fluid within the abdomen or the pelvis? Am I dealing with a possible peritonitis secondary to tuberculosis? So patient presentation again becomes key. Like the patient we had, I think in 2021 somewhere there, the presentation was just the abdominal pain. When we checked in the pelvis, the presentation was very classical of what we are seeing right now, these echogenic strands that presented there. They did culture and sensitivity and it came out positive. We went further to check in the endometrium. I think the endometrium was also affected. We checked on the ovaries on the surgery. I think the ovaries were gone with the stenchy pelvic fluid collection around. The patient also had also PID. And like I mentioned, you really have to be very careful because the other gynecological condition may present as female tuberculosis, female genital tuberculosis. So again, really you have to isolate it so that you know exactly what you're dealing with. What are some of the differential diagnoses of this? Like I mentioned, site of involvement becomes very key. So tuberculosis salpingitis, one of the differentials that you may have, like I mentioned, is pelvic inflammatory disease. You may also have cases of ectopic pregnancy. This ectopic pregnancy, again, be careful. You know, a leaking ectopic pregnancy may actually resolve to be a pelvic abscess. And this pelvic abscess may also present as a differential for female genital tuberculosis. So sometimes you can have a leaking ectopic pregnancy, and once a leaking ectopic pregnancy comes into play, it's concealed, and once it's concealed, the body will fight that and becomes just a pelvic mass. That pelvic mass, if not attended to again, it may be infected, resulting into a pelvic abscess that may present. Ovarian cysts also, which may have multiple septation, may also be one of the differential diagnoses that we may find. I mentioned about endometriosis. Be aware of endometriosis. I think 2 days back, we were doing a case where we did this case in a 23-year-old patient. So after we looked at that, the patient didn't seem to have what we were seeing, and things were not correlating. So we tried to do a TVS, and I think more information were gotten. We had this diffuse myometrium with focal areas around, and the patient, when we went further, we asked, she gave some typical presentation of endometriosis. Of course, we had to query so that other investigations can be done clinically. So carcinoma of the colon, again, can be one of the differentials. Remember, carcinomas have got a tendency of giving this ascites kind of presentation, where a patient may present with that. Diverticulitis may also be one of the differentials that may come. So you can see that for you to rule out these differentials, you really have to be thorough with whatever you may be doing. Endometrial tuberculosis, again, may also be another site of involvement, and its differentials may be dysfunctional uterine bleeding. You all agree with me that Some patients, they just present to us with prolonged bleeding, maybe for 3 months, maybe 4 or 5 months. You ask, they are not, no history of contraceptives. You check their hormonal profile, very okay. You check everything, but this patient is presenting with DUB, dysfunctional uterine bleeding. You may find that you may be dealing with a patient with endometrial or tuberculosis, which may present with dysfunctional uterine bleeding. You ask them, how is your hormonal profile? Did you do this? Everything okay. You ask them, everything seems to be okay. You ask them, but forgetting that there is this also other condition that may present within the endometrium. Ovarian tuberculosis, again, as a site of involvement, they may also present with, they may also be a differentials of ovarian malignancy. So I'll still insist, the site of involvement is very important, and it can also give you a differential. So when you look at certain presentation of this ovarian tuberculosis, they may present other pathologies that may be so confusing. And you agree with me that gyne sometimes can be so confusing simply because there is quite a number of conditions that may present, and it can mimic 1 or 2 conditions that may be so confusing. What is the key? The key is to do your lab investigations, clinical investigations, where possible, intervene. And by intervention, I mean, try to be more invasive. You aspirate and see what kind of fluid you may be dealing with. You may be dealing with hemorrhagic pelvic peritonitis. You may be dealing with fluid within the pelvis. That may be, so the color that you may pick there, it can give you quite a number of things. I think I mentioned about 4 to 5% of cervical tuberculosis. Again, this may also present as a differential for carcinoma of the cervix. Nowadays, we have a lot of cervical cancer, or rather CA. So it's now common sense that when you see a lesion within the cervical segment or the cervical portion of the uterus, we are so much biased to go down that road and think, oh, we are dealing with cervical cancer and we are likely to give that. So let's not forget, we may also be dealing with cervical tuberculosis. So the key again becomes very, very, very important. Check the history of the patient. Check any possible contact of tuberculosis. Check if these patients, they have been exposed to TB. Check these patients, the places where they have traveled and all those things. Valvular tuberculosis, you also agree with me that this valvular tuberculosis, this is more external. You are able to see on the vulva of the female genitalia. These are external genitalia structures that may be seen. So it may also present like in one of the differentials as the elephantiasis vulva. Elephantiasis vulva is very, very common in our setup. And when I mean in our setup in sub-Sahara, when you read about elephantiasis vulva, it's actually one of the most presentation which patients present with STDs, STIs. If they are in a more advanced stage, you are likely to find that they are presenting with elephantiasis vulva. I talked about Asherman syndrome. This is not Asherman syndrome, but it presents as such on HSG. Asherman syndrome, this is when the endometrium has actually adhered to each other, and when you push your contrast there, you won't see anything, but it will give you such kind of presentation that you may have. You can see these focal lesions that you may see there. These are fibrotic areas where this chronic condition may be present. So having seen this on the HSG, again, this may also give you a clue that you may be dealing with the possible female genital tuberculosis that may present. Again, one of the other differentials is Asherman syndrome, because it becomes this. So such patients again have interest and go and do investigation regarding that. Again, you may see also that there is poor peritoneal spill on the right there, but there is this peritoneal spill that you can see this other side. This is not a typical uterus that you see. And then you can see this tortuous fallopian tube with a good peritoneal spill here. But again, there is that distortion that is there. So all these investigations we need to integrate as sonographers, and when we are doing these, we can always correlate things with what is happening within the pelvic scan. Okay, sorry, I think there is one slide that is missing. But the key message about FGTP is that once we realize that the diagnosis of this requires confirmation from the combination of tests, I think this is the message that I need to present. The take-home message for FGTP is that for you to confirm the diagnosis, you need to do a number of investigations, the lab investigation, clinical investigations, and then you combine with sonographic findings, ask the history of the patient and what has been going on, and also make sure that you know the method of diagnosis that you are dealing with, and then also possibly do a transvaginal approach so that you have a clear understanding of what may be going on. And gynecologists in this case may start by gaining information through the patient history. So patient history becomes very, very key. You do the general physical examination. I talked about vulvar tuberculosis. So do general physical examination, abdominal examination to rule out any possibilities of having abdominal ascites, and then do also things like gynecological investigations that are there. Don't forget to do a chest plane X-ray and check for possible gun focus or any lesions that may be leading to a possible history of tuberculosis. Check for pleural thickening. Why pleural thickening? Pleural thickening, we know that tuberculosis, it's a chronic condition. So patients may have had exposed to this TB, and the TB has resolved, and they may present with other presentation on a chest X-ray. Check for tenting of the diaphragm. So tenting of the diaphragm on a chest X-ray simply tells you that this patient may have had a possible chronic fibrotic changes around. So there is this tenting. I think I'll show you, I have an image on that. So all those things, they may point to a possible things of a chest X-ray that may have been there. And these patients may show some possible active pulmonary tuberculosis or some odd lesions that may have presented on the past TB. This may also help you to know that it may lead you to suspect possible genital involvement. And not only that, ultrasound becomes very, very, very key to integrate these things that you may be talking about. So you need an immense diagnostic value of coming up with the female genital tuberculosis. And ultrasound also, like I mentioned, follow on certain things like heterogeneous and the thing, endometrium, check for endometrial fluid. This endometrial fluid you may also look at it. Is it clear fluid? Does this fluid within the endometrium has any echogenic debris? Does this fluid also present to be to have calcifications like the one I showed? Does it have any multiple bands that may be there? Is there anything like an intrauterine Seneca? Do we have any possible of endometrial tuberculosis? Ultrasound can also demonstrate the presence of hydrosalpingitis, like I mentioned, where you have fluid within the fallopian tubes, and you also have this cogwheel sign. People always talk about the cogwheel sign. Cogwheel signs is also a very good presentation of hydrosalpingitis. That may also present like that. And then you also have this inhomogeneous enlarged ovaries. Let's have a tendency of measuring the ovaries and actually see them that this is the right ovary, this is the left ovary, and measure them where possible. Why do you need to measure them? You need to measure them because the size of the ovary may give you a lot of information that may be there. And then check for free intraperitoneal fluid and possible fixed adnexia masses. And all these things that I'm talking about can nicely be visualized by a transvaginal approach kind of ultrasound. In organized hospitals, they are also using this hysteroscopy and laparoscopy, very, very, very good diagnostic tools that can give you a lot of information. And such patients, if you have such investigations in your hospital, please recommend. You realize that this hysteroscopy is used to visualize the endometrial cavity better than a TVS. And you may also look for normal and absence of the endometrial TB with the hysteroscopy. And lastly, you also have to make sure that these cavity are also well visualized with other investigations that are there. And since the fallopian tubes, like I mentioned, these are the main 90%, they are involved. So FGTP cases are very, very, very important to take note. And laparoscopy findings may improve the diagnosis. I know laparoscopy is very expensive depending on where you are, but this can also help you to pick these things. And there is nothing wrong as a sonographer to recommend laparoscopy if there is a strong suspicion of female genital tuberculosis. Please recommend that a laparoscopy assessment or evaluation is required. And this may improve your diagnosis. These findings include myriad tubercles that you may find. And like I mentioned, that this presentation also may also be very tricky to note. So I'm not going to talk about the treatment because we are not in therapy per se, but the treatment remains the same because we are dealing with a bacteria. So in a nutshell, the prevalence of female genital tuberculosis among infertile women is unknown for now. And people keep on doing the research on such patients, and we are likely to be having a number of these cases which we may be missing on ultrasound. And FGT, female genital tuberculosis, may result into a serious infertility, and gynecological condition and symptoms may be menstrual dysfunction and chronic pelvic pain, which may mimic PID, like we mentioned. And then more importantly, I mentioned about physical assessment that has to be done. So patients need to be treated and thoroughly investigated with all those investigations that may present. ATT, like we all know, is a treatment for TB. It needs to be taken as a TB and sufficient duration for the treatment. You agree with me that TB has got a long treatment. Others, they even do 3-4 years and so forth. But the primary treatment of FGTP is ATT, anti-tuberculosis treatment. So for patients who will perform IVF in vitro, and tubal surgery may also be considered to avoid these things of ectopic. So I think I'll end here. This was my presentation. I hope we have highlighted one or two things, and I hope we've opened up our eyes to consider female genital tuberculosis as one of the possible diagnoses when we are doing an ultrasound. Thank you so much. I hope you are not sleeping because you are too quiet. Thank you so much, Madam Moderator. I'll end here.
Thank you so much, Mr. Mulenga, the Vice President for Radiology Without Borders. This was quite an educative presentation. And as if you knew, we had a class a few days ago where we spoke about some of the things you have discussed. So we're just busy telling ourselves, you remember we talked about this and that. So it has come timely. I'm sure it is also timely for most of the people that have joined us this evening. Okay, so right away, we'll go into a session for contributions and questions. And as we are doing that, if you would like to join our WhatsApp group, please just indicate your number in the chat and the names. I'll be able to add you to that group. So for now, if you have a question, you have a contribution towards what has been discussed this evening, just feel free to raise up your hand. We'll give you an opportunity to speak. Okay. Was everything clear? We have no questions. Please don't wait for your friend to raise their hand. Feel free to just raise a hand on your own. It's not always questions. It could be a contribution, an appreciation that is acceptable too. Okay, so as we're waiting for people to come up with contributions and questions, if you have a presentation that you would like us to air, or you have a presentation. Okay. So there's a hand. I don't know if it's a Mr., but glorified at the end. Yes, please feel free to unmute.
Okay, thank you so much, Madam Chair. My question is on I think there's a slide where she was showing the site of involvement and the differentials that we could follow, we could use when diagnosing for TBS, this one. Okay, so I know like when we are doing ultrasound scan, probably in a case where you have a lot of patients, so you may see this patient and find those and have these findings. Okay, so according to what I've heard in his presentation is that you have to do a lot of tests for us to confirm that this is tuberculosis, genital tuberculosis. So, okay, there are some facilities where you would find that once the patient goes, you might not be able to maybe have the results from the lab. So in that case, I don't know how possible this could be, or on ultrasound, how like as you are examining, are you able to tell, say this is TB?
Okay,
yeah, so
I think I hear what you're trying to ask. Hello?
Yes, sir.
Yeah, I think your point is, I know in our setup, sometimes we have so much a long queue, and sometimes we want to quickly do a report and you let the patient go. I would advise that sometimes some things are obvious. You just do a report and you let the patient. But some things that you suspect and strongly suspect there could be something else going on, there is no problem, regardless of where the patient stays, to return that report and do your report later, even after, depending on how severe it is, even after 1 or 2 days, to give room to do some other investigation. Half the time when I do that, I actually come up with a very good report. Why? Because I've taken time to consult, I've taken time to read, I've also taken time to correlate other important things that I may have not seen while I'm doing that. Sometimes I even do a repeat because I've read something, I've done this, and I'm trying to put things together. Ask for a second opinion. I think for me, it's better I delay a patient and they go with a nice conclusive report or near to what may be happening than rushing into writing a report. that may not help the patient. So I think it's a good practice sometimes to return the report, 1 or 2 reports, and then you write a report even the following day or maybe later during the day, so that you reflect and digest more about that case. I think that's how I would approach that one for me.
Okay. Thank you so much.
Welcome.
All right, thank you. I see we have another hand, Mr. Paul Musonda.
Thank you, Madam Chair, and thank you, Samina, for the wonderful presentation. Though I had a problem with network, I don't know, maybe you talked about it. Maybe I'll ask just to get a clear picture concerning the FGTB. Is there any specific age group that this is targeted to have FTG TB, or do you have, it can occur in any age group? To be specific, is it a certain age group that you can able to focus? You say this age, we can suspect this. Normally, our clinicians, maybe they might miss it, but maybe on our side, we can able to pick it up and are able to help our patients. So I wanted to know specifically the age group. I don't know if you talked about it, because I was having problem with network. Thank you.
Thank you so much. Literature continues to emphasize that most of the affected age group is a reproductive age. The explanation that has been given is that during the reproductive age, there are quite a number of physiological changes and activities that goes on. But more importantly, even the exposure to tuberculosis, much as you can be exposed also when you are young, okay, still you may have other chronic changes that may occur. But literature continues to talk about the age that is mostly affected is the reproductive age. I wouldn't know the explanation to that, but the age group is mostly reproductive age. Sometimes post-menopause has also been attributed to this, but these are patients who may have had an exposure a long time. And remember, as you age, your immune system may also tend to go low. So those patients who have had the tuberculosis, which was latent, because here we also have to understand the pathophysiology of tuberculosis. Sometimes you can have a latent bacilli, which has been there for some time, and then it only triggers when you reach a certain age. So post-menopause or post-menopause in female, it may also present like that. So I think that's how I would answer that question.
Okay, thank you so much. Thank you so much, Mr. Mulenga. There's another hand from Mr. David.
Thank you very much, Madam. Mr. Mulenga, that's a very wonderful and insightful presentation that you've given us. I've got two observations, and I may just want you to comment. I think arising from what my previous colleague who raised the concern just said, I think I also want just to emphasize. I think your presentation actually has raised a lot of things that may actually help change certain protocols if active in the hospitals. For example, you talked of having a very good patient information before you actually scan the patient in order to correlate a lot of things. But the problem with that, Mr. Mulenga, is that there are rare cases where patients come with that amount of information. In most cases, you just have the patient coming with a request form that may have very few details. Sometimes even what is being asked for may not even correlate with what the patient is complaining about. And then also the other challenge is the relationship of clinicians and us practitioners. For example, you talked of having so many investigations that have to be done. to correlate with your findings. But what I've noticed is some clinicians, sorry to say this, may not be willing to undertake a lot of investigations along your opinions, because they may feel that they must be dictating their affairs regarding their patient. So it's quite a mix of issues that may require to be addressed before actually you have that freedom to even follow up the patient and have a wealth of information about the patient. Thank you very much, Mr. Mulenga.
Thank you so much, Mr. Sakanya. I agree with you 100%. In our setup, it's very difficult to do some of these things, and you end up just getting frustrated along the way. You find that you recommend this is not there, this is not there, and you lose track with the patient. So I agree with you, and it only points to one thing: the quality of our health care it's not good. And because of the poor quality of health care, we compromise quite a number of things. And I think it's not something that is so nice. It's something that should be changed. And the people to change, it's us. It's difficult as a group, but it's things the way it must be done. So unfortunately, Mr. Sakanya, that's the reality on the ground. And I think the best is to just to have this information in the background, and then where applicable, we apply it. But otherwise, it can be very tricky, like you've mentioned. Thank you so much for those comments.
Okay, thank you so much. Any other hand contribution question? Okay, so as we're waiting, like I was saying, oh, I think I see another hand. IJN, please feel free to unmute. Thank you.